If you have a patient with significant mitral stenosis, how can the use of TEE influence clinical care? Well, in this episode, we're going to cover these important considerations for patients undergoing mitral valve surgery. Welcome to Tea Time. I'm Dr. Andreas Plackis, and in this episode, episode 11, we're going to be discussing how to evaluate mitral stenosis using TEE for patients undergoing mitral valve surgery. The clinical questions we're going to address today are twofold. Number one, how can a clinician evaluate mitral stenosis to determine if a surgical intervention would benefit a patient? And then secondly, what echocardiographic parameters are used to even define valve severity in mitral stenosis patients? We want to start by defining mitral stenosis severity. A normal mitral valve area for most patients is between 4 and 5 centimeters squared. As patients start to have a mitral valve area that goes below 2.5 centimeters squared, they can start to exhibit some mild symptoms. However, it isn't until they get below this 1.5 centimeter squared cutoff that they can really start to exhibit more severe symptoms. Each of the stages of mitral stenosis severity can be defined by looking at patient symptoms, valve anatomy, valve hemodynamics, and then the effects of the mitral stenosis on left atrial and pulmonary circulation. There are numerous different causes of mitral stenosis. The major types would include rheumatic mitral stenosis or degenerative mitral stenosis. We differentiate between these because there's different treatment options available for them. Less common types of mitral stenosis would include congenital causes, inflammatory causes of it, or even radiation-induced or cardiac masses that would cause mitral stenosis. Rheumatic mitral stenosis is the most common cause of mitral stenosis worldwide. Caused as a complication of prior rheumatic fever, it occurs more commonly in women than men, with 80% of cases occurring in women. This condition predominantly affects the leaflet tips in mitral stenosis patients. It also can affect different valves as well, affecting the aortic valve and even the tricuspid valve. One of the scoring systems used to help determine if intervention is warranted is the Wilkins score. This helps predict the success of balloon valvuloplasty by assessing the valve thickening, calcification, and subvalvular chordal fusion. The other major cause of mitral stenosis is degenerative or calcific mitral stenosis. This occurs more commonly in elderly patients and especially in high-income countries. The disease process here occurs when you have calcification of the mitral annulus that extends into the leaflet bases. This causes narrowing of the annulus and more rigid leaflets as well. You do not have commissural fusion like you do in rheumatic mitral stenosis, as the leaflet tips are usually unaffected here. These patients are high risk for any intervention. They frequently have extensive calcification, advanced age, and multiple comorbidities that make them poor surgical candidates. Let's look at some of the indications for intervention in rheumatic mitral stenosis patients. The first major differentiator in the treatment algorithm is differentiating between severe mitral stenosis patients and non-severe, as defined by a mitral valve area of less than 1.5 centimeters squared. Next, we'll determine if they're symptomatic or asymptomatic. In symptomatic patients that are a percutaneous mitral balloon commissurotomy candidate, which from here on out I'll call a balloon valvuloplasty for ease of saying, that is a class 1 recommendation for balloon valvuloplasty. If they're not a good candidate, or they've failed prior balloon valvuloplasty, have severe symptoms, if they're a good surgical candidate, that's a class 1 recommendation for mitral valve surgery. If they're a poor surgical candidate, either high or prohibitive surgical risk, it's a class 2B recommendation for balloon valvuloplasty. In the asymptomatic population, we'll look at two other factors. If they have a pulmonary artery systolic pressure greater than 50, that's a class 2A recommendation for balloon valvuloplasty. And if they have new onset AFib, that's a class 2B recommendation. And although patients may not report symptoms, these can be complications from mitral stenosis, which are why they are indications for procedures. We'll swing on over to the progressive mitral stenosis category, where the mitral valve area is greater than 1.5 centimeters squared. These patients have to have exertional symptoms and hemodynamically significant mitral stenosis, where a stress test may show a wedge pressure greater than 25 or a mean gradient greater than 15 during exercise. And that would be a class 2B recommendation for a balloon valvuloplasty in those patients that are good candidates for that procedure. We'll now look at some of the indications for intervention for calcific mitral stenosis patients. If a patient has symptomatic severe calcific mitral stenosis with a valve area less than 1.5 centimeters squared with severe symptoms and extensive MAC, a valvular intervention can be considered only after discussion of the high procedural risk and the individual patient preferences and values. And that's a class 2B recommendation for mitral valve intervention. The reason these patients are high risk are that most of them have advanced age, multiple comorbidities, and high surgical complexity. Intervention should only be in the highly symptomatic patients. Severe MAC can pose numerous challenges to the surgeon by having difficulty securing a prosthetic valve, potentially leading to increased valve dehiscence or increased paravalvular leak risk. In these patients, a notable characteristic finding are that they do not have commissural fusion, so the way in which a balloon valvuloplasty that breaks open those commissures would benefit a rheumatic mitral stenosis patients, the same mechanism is not available in these patients because there is no commissural fusion. In Tea Time episode 9, we went over a 6-step structure for native valve evaluation. And we're going to use that same system to evaluate patients with mitral stenosis. Step 1, we'll start with looking at clinical information and clinical factors. Some of the clinical information that we'll look at starts with looking at patient symptoms. Remember from the rheumatic mitral stenosis intervention algorithm, symptomatic versus asymptomatic is an important differentiator in the treatment algorithm. Does the patient have dyspnea on exertion, changes in exercise tolerance, or new onset atrial fibrillation that could indicate progressive left atrial damage? Some of the major precipitants that could cause these symptoms are anything that could cause an increased cardiac output or tachycardia in these patients. Higher cardiac output, higher heart rate can increase transmitral pressure gradient, which would cause these symptoms. Think of patients who have exertion, emotional stress, fever, infection, atrial fibrillation, pregnancy. Let's also take a look at the heart rate and blood pressure at the time of the exam. The diastolic filling period and the heart rate can greatly affect gradient measurement when performing echocardiography. That's why a lot of the recommendations when assessing valve severity are at a heart rate between 60 and 80 beats per minute. Step 2 of valve severity, we'll be looking at 2D echocardiography. Using 2D echocardiography, we want to look at the mitral valve leaflet function and structure. So looking at leaflet function, let's differentiate between rheumatic and calcific mitral stenosis. Key factors for rheumatic mitral stenosis include commissural fusion. This will have a characteristic fish mouth appearance, especially when you do a 2D or 3D en-face view of the mitral valve. Number 2, we'll see leaflet thickening either with or without calcification. Number 3, for rheumatic mitral stenosis, you'll see a characteristic hockey stick or diastolic doming appearance of that anterior mitral leaflet. And number 4, you may see chordal thickening and shortening in these rheumatic mitral stenosis patients. For calcific mitral stenosis, you'll see non-mobile leaflet bases with mobile leaflet tips. And you can also see this calcium by noting hyperechoic calcification with shadowing occurring underneath those calcium deposits. For mitral valve structure, we'll take note of thickening, calcifications, chordal shortening and thickening. For rheumatic mitral stenosis, you'll see thickened and rigid leaflets. In the calcific patients, the leaflet tips are pretty normal. In the rheumatic mitral stenosis patients, the defects occur first at the leaflet tips and work towards the base of the mitral valve. This is the opposite as in calcific mitral stenosis, where the defect and the calcium occur at the mitral valve base and annulus first, and then work their way more towards leaflet base and tips. Step 3 in the native valve evaluation will be looking at Doppler echocardiography. Using color Doppler, one of the first things you may see is proximal flow convergence on the left atrial side of the mitral valve, and then you may see turbulent flow after the mitral valve. We can also use spectral Doppler to evaluate these patients. One of the major tools we have is using mean gradient. That is a level 1 recommendation for evaluation of the mitral stenosis patient is to use mean gradient. We'll perform this by performing continuous wave Doppler through the mitral valve in a mid-esophageal view, either the mid-esophageal commissural or long axis view. Remember, the mean pressure gradient is better than the peak gradient, as that peak gradient is more influenced by left atrial compliance and LV diastolic function. Report the findings here with the heart rate, as that higher heart rate can increase the mean gradient and overestimate valve severity. And in atrial fibrillation patients, this mean gradient needs to be averaged over 5 cycles to be accurate. In degenerative mitral stenosis patients, mean gradient is a good marker of valve severity as there's some significant limitations to planimetry and pressure half-time in degenerative mitral stenosis patients. Let's look at a few of the factors that it's important to be aware of that can influence the mitral valve mean gradient. The first of which is being aware of a possible double envelope sign. There can be a double envelope artifact, and you need to measure the smaller one here to get a true mean gradient. Some of the ways that you can get rid of this double envelope artifact include shifting your Doppler beam slightly to change it, or turning down the Doppler gain setting to get rid of the artifact that makes that mean gradient look much bigger. There can be technical errors that can occur where your Doppler beam is not properly aligned that can give you inaccurate gradient measurements. Remember, when you measure any gradients, the gradients will always be flow dependent. High flow states, and in this case with associated significant mitral regurgitation or high cardiac output, will increase this gradient artificially. Low flow states, where you have low cardiac output, or even obstructive valves like severe aortic stenosis, will lower that gradient, even if valve stenosis is more severe. We'll also take note of LV diastolic function and compliance. Lastly, increased heart rates will cause increased mean gradient measurements. We can also assess pressure half-time. This also is a level 1 recommendation when assessing mitral stenosis severity. The actual formula here is the mitral valve area is 220 divided by the pressure half-time. This is validated for rheumatic mitral stenosis patients, not calcific mitral stenosis patients, and we'll talk about why that's important here. The way this is performed is using continuous wave Doppler and tracing the deceleration slope of the E wave on the Doppler spectral display of the transmitral flow, and it'll measure the time at which the peak pressure becomes the half pressure, essentially the pressure half-time. And a way to remember this is that the longer blood takes to flow through a valve because it's more stenotic, the longer and greater the pressure half-time will be. So increased pressure half-time is a lower mitral valve area. Lower pressure half-time would indicate a higher mitral valve area and less severity. There's a few confounders to be aware of when using pressure half-time in your assessment. Severe aortic insufficiency can increase your LV filling rate, as both the mitral valve and the aortic valve will fill that LV cavity, causing premature mitral valve closure. Mild to moderate AI really shouldn't significantly affect pressure half-time, but severe AI will play a factor here and can give you inaccurate measurements. Impaired LV diastolic function leads to the lower reliability in elderly patients. This is why it's frequently not used for degenerative mitral stenosis evaluation. And I'll quote this directly from the guidelines: the use of pressure half-time in degenerative calcific mitral stenosis should be avoided. Sometimes you will have this bimodal distribution of the deceleration slope of the transmitral inflow. Remember, trace the slope in mid-diastole rather than that early deceleration slope. That's how you're going to get accurate measurements. Trace the middle part of that E wave. Step 4 in the native valve evaluation will be using quantitative measurements to determine valve severity. The first quantitative measurement we can use is 2D planimetry. This also is a level 1 recommendation for assessment of mitral stenosis severity. You can do this 2D assessment by obtaining a transgastric view, and then I would perform an X-plane through what appears to be the smallest part of the mitral valve area, and it'll give you the short axis view here. The reason I do this is because the mitral valve will appear like a funnel, and you have to get the plane that is the most downstream on the mitral valve, the smallest part of the funnel, to get a true mitral valve area. Ensure that you're measuring at the leaflet tips. This must be done at mid-diastole when the mitral valve is most open. This is a helpful tool to use in low-flow, low-gradient mitral stenosis where a mean gradient might not be as reliable. Some of the errors you may see in this method are that it can overestimate the mitral valve area. If you locate the narrowest orifice, that gives you the true mitral valve area. But if you're higher up on the mitral valve or your plane is slanted, it's only going to give you greater areas of that mitral valve that are incorrect and not the actual mitral valve area. Also, in those calcific mitral stenosis patients that have extensive calcification, it can be hard with those calcium deposits to get a true narrowest orifice area and planimeter that area correctly. The other method that can be used quantitatively is PISA, or proximal isovelocity surface area method. This is important to learn for echo boards and just to know if you're still learning echo, but I personally don't use this in any of my mitral stenosis severity assessments because there's so many measurements that I think it makes this method prone to error, and there's other better tools to be used. However, I'll still walk you through at least some of the things that you have to know. You're going to use this long mitral valve area equation and measure a few different things. The things that you need to measure include the radius of that proximal isovelocity shell, the aliasing velocity that you'll see on the color scale in the upper right corner of your echo assessment. You'll also assess the velocity of the transmitral inflow and then angle correct for the mitral valve as well. This method is prone to error because it's technically demanding. It requires multiple measurements. If there's any errors in measurement of the radius, those errors will be squared as well. You also have to calculate the alpha or opening angle, unlike regurgitant lesions, which can further introduce an area of uncertainty as to the accuracy of your measurements. Also, another quantitative measurement that can be used is the continuity equation. I do not use this, but you do need to know it for your echo boards. This assumes that the volume that goes through a mitral valve is the same as the volume that exits through the LVOT. However, this cannot be used in cases of significant mitral regurgitation or aortic regurgitation, or in cases of atrial fibrillation. It's not well validated, and it's infrequently used because of it. Step 5 in our native valve evaluation is using 3D echocardiography in the mitral stenosis assessment. The first part that can help us here is locating particular valve pathology, especially if you need to further look at your mitral annular calcification. This can oftentimes be best seen in that 3D view, and you can further specify if you need exactness using multiplanar reconstruction. Also, you can assess mitral valve area using 3D planimetry as well. If you perform this without multiplanar reconstruction, keep in mind that if your en-face view is tilted at all, it will underestimate the mitral valve area. That's why I think the way this should be practiced every time is using multiplanar reconstruction to get the accurate plane and get the true mitral valve area. This needs to be done in mid-diastole when the mitral valve is most open and with optimized gain settings, especially in the calcific mitral stenosis patients, to get the truest leaflet edges so you can measure that planimetry area. I want to give you an actual example of how to perform 3D planimetry for mitral valve area. This video goes quick, so feel free to pause it, rewind it, or re-listen to it as needed. Start by acquiring a 3D zoom data set of the mitral valve. Find the mid-diastolic frame where the mitral valve is maximally open. Then use your multiplanar reconstruction to align your red and green planes perpendicular to the smallest mitral valve opening. You'll use that blue plane and find the smallest part of the mitral valve opening, and then zoom in on that short axis view of the mitral valve to be able to trace the mitral valve area. And that's how 3D planimetry is performed for mitral valve area. Step 6 and the last step of native valve evaluation for mitral stenosis is using other cardiac data. The other cardiac data that we'll look at when assessing mitral stenosis severity include looking at the LV size and systolic function. I would not expect any major changes from mitral stenosis alone, but frequently these patients are older and sicker, and it's important to have a baseline when you start surgery. I'd also look at the left atrium and left atrial appendage, as frequently the left atrium will dilate in patients with chronic mitral regurgitation and mitral stenosis, making them prone to atrial fibrillation. And because they're prone to atrial fibrillation and have low flow through that mitral valve, they are more prone to stasis and thrombus in that left atrial appendage. We'll want to assess the RV size and function and any underlying pulmonary hypertension. RV dysfunction is common, especially with chronically elevated pulmonary artery pressures. The pulmonary hypertension can lead to increased pressure on the RV and right atrium, and they can cause subsequent RV and right atrial dilation and dysfunction and subsequent functional tricuspid regurgitation. We'll want to assess baseline aortic valve function, as aortic insufficiency that's severe can confound our Doppler assessment of the mitral valve, making that pressure halftime assessment not valid. Also, aortic stenosis can cause low flow states that artificially lower the gradient through the mitral valve. In patients that do have significant mitral stenosis that cause low flow states, it can also artificially lower the aortic stenosis gradients and severity. So that's something to be in mind when you have mixed valve pathologies in certain patients. Lastly, Keep in mind in rheumatic mitral stenosis, rheumatic disease can cause valvular problems in the mitral valve, but then also, next commonly, in the aortic valve. And last but not least, we want to make sure to get a good assessment of that tricuspid valve. Moderate tricuspid regurgitation that does not have a dilated annulus often can improve after mitral valve surgery. However, if you do have progressive tricuspid regurgitation, which is defined as non-severe and non-symptomatic, either mild or moderate, that has annular dilation greater than 4.0 centimeters, or the patient has prior right-sided heart failure symptoms, there is a Class 2A recommendation for subsequent tricuspid valve intervention during the left-sided surgery. So that's why it's important to determine if a dual intervention is needed during a mitral valve surgery. Let's wrap up this podcast episode by looking at a few key points. Number one, look at the etiology and severity of the mitral stenosis, as these are a few major factors that influence the mitral stenosis decision pathways. Number two, the big three ways we evaluate mitral stenosis are with planimetry, mean gradient, and pressure halftime. And lastly, point number three, both PISA and continuity equation have low perioperative clinical relevance compared to other methods. There's numerous sources of error, not well validated. Use those big three in point number two here. Those are going to be your bread and butter for mitral stenosis evaluation. The next episode, we will apply what we've learned in this episode and last episode, how to evaluate mitral regurgitation and mitral stenosis, and we'll apply it to using TEE in mitral valve replacement surgery. So we'll try to really tie these two episodes to a very high-yield, clinically relevant episode. Thank you guys for watching. If you want more of this content, hit that subscribe button, leave us a review. If you want to share your own experience, it's always good to learn from other people at other institutions. Feel free to leave a comment below. Let us know what you do if you have any different practices where you are, and we can all learn from each other. But thank you guys for watching. We'll see y'all next time.